If you've heard me talk before, you often know that I sometimes start by giving you the quirky holidays of the day as a kind of an icebreaker. But earlier today, I was listening, and I thought maybe I would change that up this time because I heard a great quote, and I think it applies not only to cardiology, but to many other things in life. And it's really true. You just don't want your suction to suck. So just remember that. So let's talk about hypertrophic cardiomyopathy. So what is it? It's this disease that is a genetic predisposition to the heart muscle being too thick. It impacts 1 in 500 people around the world, most of whom live a near normal lifespan and most of whom live a good quality of life. But there's lots of things that we have to consider, and again, they asked me to talk about risk stratification, some of the diagnosis, and then how you manage patients with their symptoms. So yes, these are autopsy specimens, and it's important to recognize that people can die suddenly from this disease. So when you look at an echo or an MRI or anything else like that, and you see something that has thick walls, there is a differential diagnosis. It's not just hypertrophic cardiomyopathy, but mostly all these other things tend to have other stuff that goes with them, like renal failure or neuropathy, or they have ataxia. So usually when you have increased wall thickness and no explanation for that heart muscle thickness, hypertrophic cardiomyopathy is the most common diagnosis. Now, athletes are a special a version of that, and there's going to be a talk on the last day, or next to last day, about whether they can participate in sports. So HCM is this overlap with athletes, but it is really hard to exercise to make your heart muscle get thick. That's not what happens when you exercise. Your chamber gets bigger because you need a bigger stroke volume for all the reasons that Chris was talking about with diastolic function. The heart muscle rarely gets thick when you train it, so the overlap there isn't that big. There are these great things that Barry Marin has published about criteria that look more like HCM and criteria that look more like athlete. The bottom line is that the heart muscle looks a little bit big and everything else looks really normal, that's an athlete. If there's signs of pathology like bad suction, big left atria, valvular abnormalities, then that's probably hypertrophic cardiomyopathy, and particularly the person who has great exercise capacity versus not what you would expect. So while that was a big thing that we get faced with in clinics, it often isn't that often that we are confused. There used to be this notion that you could take an athlete and have them stop working out for 6 weeks and their heart muscle would get thinner if it was due to athletic adaptation. Try telling a competitive athlete to stop working out for 6 weeks. But the other thing is that we have a gene-positive HCM patient